Hello, my name is Pat Rhyner, and I am going to be speaking with my dear friend and colleague, Dr. Ashley Aiken, on a session about head and neck cancer. And I'm hoping, sincerely hoping, that we will be able to get together again soon with the ASHNR. I certainly miss all my friends and colleagues in the ASHNR. I hope you'll let me have a little humor, a little stupid humor. These are the Talking Heads, a big band that I loved when I was a teenager. I have no relevant financial relationships that will impact this presentation. Now, I have several goals in this presentation, and they are these. I'd like to recognize the importance and the basis for staging cancers, and cancers not just in the head and neck, but throughout the body, and how the staging impacts so much that is important to that patient, especially treatment and prognosis. The TNM staging for head and neck cancers has changed in the past several years with the development of the AJCC 8th edition, and I'll go through some of the changes. And it's very important in this day in 2020 to recognize the differences in staging, whether an oropharyngeal tumor is HPV positive or HPV negative. And P16 is a surrogate marker for HPV, and it is what we always ask our lab to do when we do an FNA of a node. I'd like to thank Amanda Corey. She was my partner for a very long time, and many of these beautiful images are from Amanda. So in the AJCC 8, the pharynx itself has been restructured. And there are now 3 separate pharyngeal chapters. And these have developed as our knowledge of the science and the behavior of these tumors has become, our knowledge has become more in depth. We understand more about these tumors now. And that is the beauty of the AJCC system, that as science progresses, the impact is immediately acknowledged by the Joint Commission of Cancer, and the staging will change. So this is a dynamic book. The AJCC manual is dynamic. It changes periodically as the science develops. So the nasopharyngeal carcinoma, these tumors have their own chapter now. It is known that these are very different tumors than tumors of the oral pharynx. The biology is different and the prognosis is different. I don't plan to cover the nasopharyngeal tumors today. There are 2 separate chapters for the oropharyngeal and hypopharyngeal lesions. Oropharyngeal tumors that are HPV negative behave in a similar manner to hypopharyngeal tumors. The biology is similar, the risk factors are similar, and those tumors are covered in one chapter. We know now that the HPV positive tumors have very different biology and prognosis. So oropharyngeal tumors of the tonsil, the base of tongue, or the posterior pharyngeal wall that are HPV positive have a very different behavior from tumors that are HPV negative, and they therefore have their own staging system and their own chapter. And a reminder that in order to adequately stage a tumor, you have to be familiar with the concept of the subsites in the head and neck. And very briefly, these are the nasopharynx in this location. The oral cavity is anterior to the circumvallate papilla. This is the oral cavity. Oropharyngeal is posterior to the papilla, and this is where the P16 positive, HPV positive tumors arise. Inferior to the hyoid bone, we have the hypopharynx, which is posterior, and the larynx, a more anterior structure. Tumors in these 5 subsites behave differently, and that's why it's important to know the subsite and to use the appropriate chapter when attempting to stage. So I'm going to use a couple of examples of head and neck squamous cell carcinoma and show how the process of assigning an imaging stage. And two critical pieces of information include knowing the staging criteria, which is in the manual, AJCC 8, and then knowing the subsite where you believe this tumor started. And it's often very obvious, but when tumors are large, it can be tough to know the subsite or the site of origin of the tumor. Now, as a background, staging attempts to describe the size and the extent of the primary tumor at initial presentation before there's been any treatment. Now, this is a common language that is used by all the specialties that care for patients with head and neck cancer: radiation oncology, hematology oncology, otolaryngology, and head and neck radiologists. We all use the same common terminology, and that is staging. It is a critical knowledge to plan the treatment. Stage of a tumor estimates the prognosis, which is very helpful to the patient, and it will help determine whether the patient is adequate for clinical trials. And the clinical stage is assigned without imaging, but it is obvious to all of us that imaging plays an increasingly important role in staging and follow-up of cancers that are found everywhere, not just in the head and neck. But in the head and neck, the deep extension of the tumor can't be seen on physical exam. The examining physician can see the mucosal ulceration, but the deep extent cannot be seen except with imaging. And that, unfortunately, would lead to understaging a tumor, and that would lead to undertreatment. Remember that the initial stage doesn't change during treatment. So post-treatment imaging, we don't restage the tumor. We talk about whether there's persistent or complete resolution of disease, but the initial stage is maintained throughout the course of that patient's treatment. Now, the tumor node metastasis system, the TNM system, includes the primary tumor, the nodal stage, and the distant metastases. And today I'm going to emphasize the primary tumor stage and the process of staging. It is easiest, as many things in radiology are easiest, when the diagnosis is known. So when you know the patient has a laryngeal tumor because they're hoarse or they have a big tonsil mass. And it is helpful when there are unequivocal imaging findings. And that's always the problem with our field, is the diagnosis is not always known. And sometimes the findings are not unequivocal. But I'm going to go through some imaging of the best case scenario to stage two tumors. So this is our universal guideline, the AJCC manual. It comes in different forms, electronic and hard copy. As I said earlier, it is periodically revised. As our knowledge of science and tumor behavior evolves, the manual will change. This 8th edition was published in 2016, and we have some very, very good head and neck radiologists that were on the committee to develop the head and neck portion. And you may benefit from knowing that there's also a staging atlas. But this should be on your worktop, your desktop, or a hard copy in your reading room. Now, there are a couple things, changes between the old edition, the 7th edition, and this 8th edition. And the main changes are in the oral cavity, and I will show you how on imaging some of those changes have occurred. But now it is important to know the depth of invasion, and that is determined by the pathologist. And that replaces what was often difficult to prove, which was extrinsic tongue muscle invasion by tumors. The HPV-positive and HPV-negative tumors have different chapters and different staging. Nasopharyngeal has changed, and the nodal staging for head and neck cancer, extranodal extension is now emphasized in the nodal staging. One more time, you have to know the subsites. You have to know that the nasal cavity and sinonasal cavity is anterior, The nasopharynx, the boundaries of the nasopharynx, you've got to know it's above the hard palate. The oral cavity, remember, is anterior to the circumvallate papilla. Oral pharynx is posterior. Larynx is anterior, includes the epiglottis, and the hypopharynx is posterior. Just some brief anatomy and description of the changes in the oral cavity staging. Now, the oral cavity anatomy is complicated. It includes the lips, the anterior or mobile portion of the tongue, the floor of the mouth beneath the tongue. It includes the gingiva that is overlying the mandible and maxilla, and the retromolar trigone, that area that is mucosal covered and right behind the last maxillary or mandibular molars. And it includes, the buccal mucosa, which is usually collapsed when we do our cross-sectional imaging. But you can see here that there is a tumor in the depth of the buccal mucosa posteriorly on the left, but that is an important area in the oral cavity. The oral cavity is easily examined. This is the dorsal tongue. When the patient puts their tongue on the roof of the mouth, we're looking at the ventral tongue. In this particular image, the mouth has been pulled laterally, the lips have been pulled laterally. We see a nice look at the mandibular teeth. This is the lingual sulcus here, the tongue, of course. This is oral cavity. And what we're seeing here is the buccal mucosal sulcus. This is the tumor, a mucosal ulceration there. Again, we're just seeing the tip of the iceberg. We don't know how big this tumor is beneath this, but it is located in this buccal sulcus. And this is the gingiva that is the mucosa lining the mandible and is around the teeth. Here's a patient who has a large torus right here, torus palatini, and he has a bulky tumor at the junction of the oral tongue and the posterior base of tongue. And again, it's easily examined, but what's happening beneath that tumor, size and extent, is our responsibility. This is a nice look at the floor of the mouth. This is a bulky tumor in the midline anterior floor of the mouth. You can see this is the mandible. The buccal sulcus here on this side is the lingual sulcus and floor of mouth, the ventral tongue right here. This tumor is on the mobile portion of the tongue. This is the portion of the tongue that can be moved, just as the name would imply, the mobile tongue. This is the collapsed buccal sulcus here. This would be expanded if we had the patient fill the cheeks with air. This bulky tumor is present on the anterior and paramedian oral tongue. This is another oral cavity tumor, and it is present in the floor of the mouth. And you notice that the oral tongue is relatively featureless, but the floor of the mouth is a very complex area on cross-sectional imaging. This is the interface between the oral pharynx and the oral cavity. So everything anterior is oral cavity, everything posterior is oral pharynx. These are the genioglossus and geniohyoid muscles that insert anteriorly on the genioid tubercle of the mandible. And here is the tumor, right in the anterior sublingual space. These are the glandular tissue here, and this tumor is in the anterior right sublingual space. This is a very characteristic wasting appearance of the atrophic edentulous mandible in the elderly patient. You can see how the mandibular body kind of narrows there. And this is very, very characteristic in the aging patient. So oral cavity tumors are important for us to be able to see with our imaging. The staging for the first three is based primarily on size. 2 centimeters, 2 to 4 centimeters, or over 4 centimeters, or the depth of invasion. And that is not our responsibility. That is the responsibility of the pathologist. These tumors are resected en bloc, not usually in a piecemeal manner, and so the pathologist can determine the depth of invasion. Notice that once the tumor destroys bone, It is a T4 tumor, and there are some subtleties that differentiate T4A from T4B. One is extension into the masticator space. So in the AJCC 7, part of the radiologist's responsibility was identifying the little tiny extrinsic tongue muscles. And this is the very small hypoglossus muscle, and we had to identify that muscle and determine whether the tumor had invaded that muscle. Beautiful MR image here with the high signal intensity in the mandibular body. Mental foramen is right there. Genioid tubercle of the mandible is here, and the genial glossus and hyoglossus and genioglossus muscle are inserting here on the genioid tubercle. Sublingual space is here with the glands, and then back here is the interface between the oral pharynx posteriorly and the oral cavity anteriorly. On this T2 weighted image, this shows what is now used for the staging, and that is the depth of invasion or the depth of the primary tumor. We get a sense of it on imaging, and we usually report it, but it is the pathologist's description and identification that will be used in the final stage. Here's an example of an oral cavity tumor on T2 fat-saturated MR. We can see it started here on the dorsal tongue. This is the maxilla, the incisive canal right there. A little bit of the uvula there. I'm sorry, my mouse is so sensitive. A little bit of the uvula right there. As we get down into the bulk of the tongue, we can nicely see this tumor extends to the posterior last molar here. It's at the retromolar trigone. And notice how this tumor has spared the deep floor of the mouth. The anatomy in the floor of the mouth is preserved, and the tumor does not get that far inferiorly. Notice the pathologic anterior to a node on the right, a characteristic appearance for a metastatic node. Now, these two separate tumors are both T4A. They're oral cavity, they're T4A. Why? The bone is destroyed. This is not a particularly nice or technically good CT, but we see the tumor easily here, and we see on the bone algorithm an unequivocal destruction of the periosteum and invasion and destruction of the mandible. This is a different tumor, big tumor. Crosses the midline. It's predominantly started on the right side, unequivocally in the oral cavity. Here is the interface between oral cavity and oral pharynx right here. And on the bone window, you can see a very large area of destruction of the cortex. Notice that on the right side, this tumor has obstructed the duct to the submandibular gland, and you have an atrophic gland, whereas on the left, the tumor has probably recently crossed the midline, recently obstructed the sublingual duct, and you can see an obstructed sialinitis involving this gland. Now, as I said, in order to be able to help with staging, we have to see the tumor. And that's why virtually all of us re-angle and rescan through the amalgam artifact of the oral cavity, unless you're adept and you have a dual energy CT scan that you're using routinely. And this is a great example of amalgam artifact that completely obscures the tumor, but once we re-angle, on a delayed image, we can nicely see the right lateral oral cavity tumor. So let's start with our two different cases. This is the first case, and it's the process of how you stage. This is a 60-year-old man with a new neck mass. Really very typical presentation. Found a new mass either when he was shaving or tying his tie. He has an ultrasound. It shows a pathologic level 2 lymph node, which we can see right here. FNA of the mass shows squamous cell carcinoma. So this is a metastatic level 2 node. Where's the primary tumor? We cannot stage a tumor based only on the nodal metastases. In 2020, this is probably an HPV-positive oropharyngeal primary tumor, since that is the tumor that is most prevalent right now in the United States. And in fact, on physical exam, here is his right tonsil. It's big and it's very firm. There is a mucosal ulceration right here that's about a 1 centimeter in maximum width. And beneath it, the surgeon can feel a bulky, a really hard tonsillar mass. So based on the clinical exam, it's probably about a T2 tumor because they can feel a mass over 2 centimeters. They biopsy this mucosal lesion in the office. It's squamous cell carcinoma. And now we are going to try to stage the tumor. Just a reminder that if you're doing ultrasound-guided FNAs of nodal masses or nodal metastases, the best algorithm is to do 3 separate passes, FNA. Most head and neck cancers are squamous cell carcinoma, and for the most part, a core biopsy is not needed. You check your FNA results with an on-site cytotechnologist, and you be sure that they send part of the FNA sample for P16 stain. The P16 is a marker for HPV. So just getting a biopsy or an FNA of a node to show that it's squamous cell carcinoma is only part of the radiologist's responsibility. You have to request a P16 stain from the lab. So let's look at the oral pharynx. This is probably where the tumor arose, just because that's what's prominent or prevalent right now. The oral pharynx is made up of the tonsil, the base of tongue, the soft palate, and this posterior pharyngeal wall. Now, the imaging on this patient, the CT, same patient, shows a right tonsil mass. That's no surprise. That's what we suspected based on the fact that this tumor is very prevalent right now, and that's what the surgeon found. And how do you start staging this? Your dictation, if you just say this is consistent with the known mass, well, that's a worthless dictation because they already know there's a mass there, and in fact, they've already biopsied it. So we have to know the HPV status before we begin the stage. Here's the primary tumor right here. It is in the right tonsil. It looks like it's gone through the lateral tonsillar fossa and into the deep soft tissues around the tonsil. This is the pathologic node that underwent the FNA, and we can see here that the tumor went all the way down the base of tongue into the right follicula. So previously, there was only one chapter or one stage for oropharyngeal tumors. Now we know that HPV positive and HPV negative tumors are very different. So there are 2 separate staging systems. And we don't know which one to use unless we know the P16 status. These are 3 separate charts that really show the importance of knowing this tumor and the behavior. This chart shows on the x-axis time, and notice that this is taken all the way out to 2030. And this shows that the cervical cancers that we saw in the late 1990s and early 2000s that were HPV positive are on a downward trend in frequency. They're much less common now. But look what's increasing in frequency and is projected to increase all the way out to 2030. And these are tumors of the oral pharynx that are P16 positive, HPV positive, especially in men. This is even a more dramatic slide. This shows the annual number of cases. And again, the cervical cancer is going down in frequency all the way out to 2030. But notice what's happening. Oh my goodness, so sorry. Notice what's happening to the oropharyngeal cancers. They are increasing in frequency. And then this just really emphasizes one more time why you have to know about the oropharynx. A dramatic rise in oropharyngeal cancers all the way out to 2030, while every other tumor in the head and neck is decreasing. HPV positive tumors, of course, we're familiar with this, are found in younger patients. They tend to have a better prognosis, and the risk factors are not tobacco and alcohol related, but are more related to a sexual behavior history. So we know this tumor, or I'm going to tell you the tumor we just looked at is P16 positive. It's HPV positive. This is the staging for the HPV positive oropharyngeal tumors. So the first three, again, depend on the size, and whether it's a T4 tumor it depends on whether it extends outside of the tonsillar fossa. The negative staging, HPV negative, is also depends on size, and then other nuances to determine whether it's T4A or T4B. So this tumor, I'm going to tell you, did not extend to the lingual surface of the epiglottis. The mass was not 4 centimeters, so it doesn't quite meet a T3 stage, but could it be T4? And remember, what are the specifics for a T4 tumor? T4 tumors extend to the extrinsic tongue muscles and the medial pterygoid. And this tumor definitely extends out of the tonsillar fossa to the medial pterygoid. And therefore, this tumor has to be a T4 based on imaging. This is a nice summary dictation. There's a 3 centimeter right tonsillar mass that extends laterally to involve the medial pterygoid muscle. There's no extension to the lingual surface of the epiglottis, the lateral pterygoid muscle, the pterygoid plates, or the nasopharynx. And this dictation, these subsites are chosen because they're listed in the staging. These are not subsites that are chosen just because that's what I want to throw into my dictation. They are other subsites that we have to describe for an oropharyngeal tumor. Here's my impression. Right tonsil mass is T4 based on imaging. And of course, if you're not comfortable with putting the stage in your dictation, you just put enough in your dictation so that the tumor board can do an accurate stage. So remember, the tumor started as a T2, according to the referring provider, based on size, and imaging alone upstaged this mass to T4, based on extension to the medial pterygoid muscle. Going to emphasize the need to know the difference between the oral cavity and the oral pharynx. They are different tumors, even though they may only be several millimeters apart in location. They behave differently, they are treated differently, and the prognosis is different. And on cross-sectional imaging, important to remember that the oral pharynx is the base of tongue and tonsil are the most important subsites, and the oral cavity is anterior to that circumvallate papilla. So this is an oral cavity tumor, anterior on the oral tongue, the mobile portion of the tongue, while this is an oropharyngeal carcinoma in the tonsillar fossa. 98% of the time when you see these tumors, they're going to be squamous cell carcinoma. Critical to know the difference between the oral cavity and the oral pharynx. The oropharyngeal tumors that we're seeing now are virally mediated. There are a variety of options for treatment where oral cavity tumors are generally treated with surgery, and the prognosis is very different. I have noticed, and perhaps you have too, that oral cavity metastatic nodes tend to be small, and that's where PET is so important, where oropharyngeal metastatic nodes tend to be larger. So the nodal, where I'm not going to get into the nodal staging, but the AJCC 8 does emphasize HPV tumors does emphasize whether there is extranodal extension. And it's important to know that the HPV positive nodes often look like they have extranodal extension even when they don't pathologically. And so if I know a tumor is P16 positive, HPV positive, I am very cautious before I call extranodal extension. The nodal has to be really invading the SCM or invading the soft tissues around the node. If it's P16 negative, the extranodal extension is an easier call. So for example, this necrotic pathologic node, I would call this just a prominent anterior level 3 node. If it's P16 positive without extranodal extension, if it's HPV negative, I would be concerned about there being extranodal extension with some dirty fat posteriorly. Of course, that will all be determined by the pathologist. Next case. This is the second case. This is getting towards the end of this discussion. This is a patient with a new onset hoarseness. His exam shows a right area epiglottic fold mass. Where is the primary tumor? Area epiglottic fold, we know, is one of the subsites of the supraglottic larynx. So this tumor is in the supraglottic larynx. It is, of course, squamous cell carcinoma. That's almost never a question. Remember, there are 3 subsites in the larynx, the glottis, the supraglottis, and the subglottis. It's important to try to make a determination of where the tumor arose. Large laryngeal tumors, you may not be able to tell. Let's assume this tumor is supraglottic. The referring doctor's note says the vocal cord is not moving, and that's an important thing to know about laryngeal staging. Here's our cross-sectional imaging. Bulky mass in the supraglottic larynx, invading the preepiglottic fat and both the left and right paraglottic fat, and involving the right area epiglottic fold. So that's what we need to know to be able to start to stage this tumor. Laryngeal tumors that involve the preepiglottic or paraglottic fat are automatically T3 tumors. So knowing that this tumor is in the fat, automatically we know this is at least a T3 tumor. Could it be T4 tumor? We'll notice that the T4 tumors advance through the outer cortex of the thyroid cartilage. So we go back to our imaging and look at the thyroid cartilage. And several millimeters below the initial image, notice that there's a large area of destruction of the right thyroid cartilage. There's extrathyroidal tumor, and so this tumor has to be at least a T4A. Based on this one image, this tumor is at least a T4A. Here's the same patient, image is slightly lower, and we can see there's edema and tumor in the infrahyoid strap muscles. So this is a T4A tumor. Here's a sample dictation, a bulky right supraglottic tumor that invades the pre- and paraglottic fat. By that one sentence, the reader knows it's at least a T3 tumor. Then we say there's a long segment of right thyroid cartilage destruction and tumor invades the infrahyoid strap muscles. The reader knows automatically this is at least a T4A tumor. So in summary, the AJCC staging manual is your guideline. It tells you what to put in your dictation. It is very important with the increasing incidence of oropharyngeal tumors because of HPV positivity. We have to know the difference between the oral cavity and the oral pharynx. It's important to determine the subsite of the tumor, check the AJCC 8th edition, know what has to be included in your dictation to stage the tumor, and as the tumor meets each stage in your determination, check the next stage to see if you should upstage the tumor based on that description. Your dictation should include what you think the subsite is, size of the tumor, and any details about that tumor that are needed to assign a stage. All radiology practices are different. Your tumor board may not want a stage in your dictation. Many of them, once you start putting a stage, they are grateful that we have taken that much initiative in the care of these patients. If you don't want to put a stage, fine, but you have to include in the impression details that are needed to stage the tumor. And with this approach, the head and neck imager is absolutely critical in the healthcare team. And of course, this always improves patient care. Here are my 2 email addresses. Please feel free to email me any questions. And I'm very, very happy to have done this lecture, and I look forward to seeing or meeting all of you when this is all over and we're back to, quote, normal. Thank you.
Good afternoon. I want to start by thanking Callie and Christine, first for the vision to create this ASHNR webinar series and for giving me the opportunity to be a part of it. I'm especially excited to be lecturing even virtually with Pat on head and neck cancer. And now I'm going to cover the difficult topic of imaging the post-treatment neck, the timing of surveillance, and how to categorize imaging findings from expected post-treatment changes to focal radiation changes that may mimic tumor, to findings highly suspicious for tumor recurrence. NI-RADS can actually make these cases simpler to interpret, saving you time, adding confidence and clarity to your read, and saving the referring clinician's time and energy in deciphering your level of suspicion, and finally, adding value for our patients. We're going to start with the definition and the goals of NI-RADS, and then move on to who and when and where we should be using this template. And finally, we're going to spend the most time on practical application and imaging examples, along with some frequently asked questions and lessons learned. NI-RADS is a risk stratification system and a template for surveillance imaging after treatment for head and neck cancer, with 4 categories of suspicion that we are going to review. The major goal is to standardize the way that we describe and report findings in order to add value and guide management. Who should we be using this template on? Head and neck cancer patients after definitive treatment, and when brings us to the next slide. This is the ACR NI-RADS surveillance recommendation in the asymptomatic patient. It is important that we define surveillance, which refers to evaluation of an asymptomatic patient after definitive treatment with curative intent. It's not imaging in the middle of therapy, that's monitoring response, and not imaging during palliative treatment, that's often also monitoring response, bigger, smaller, and may have a different timetable. Asymptomatic patients are going to undergo clinical surveillance, primarily for mucosal recurrences or palpable abnormalities, and then imaging surveillance for submucosal recurrences and non-palpable lymph nodes. Imaging surveillance should start approximately 3 months after the completion of treatment, often at the end of radiation therapy, and if that's negative, we move out to 6 months, and then another 6 months, and then we can move out to 12 months. It's important that we can interweave MRI into this algorithm for any tumors in and around the skull base. So sinonasal tumors, parotid tumors, nasopharyngeal carcinomas, anytime we're worried about perineural, intracranial, or intraorbital disease. Here are the ACR NI-RADS categories. Category 0, this is a holding pattern waiting on priors, so I do not give this often. This is when I know the priors are imminently available for review, and then I'll score after reviewing the priors. Category 1, this is no evidence of recurrence. Category 2, low suspicion, and as we'll discuss, we divide these into a 2A if it's superficial, because that's really in the purview of our surgeons to assess, and then 2B if it's deep, because these are the deep ill-defined abnormalities that we just need more data to decide whether it's no evidence of recurrence or whether it's high suspicion. And usually that more data comes with shorter follow-up or a PET. Category 3, these are high suspicion of recurrence, discrete, new or enlarging, and have intense FDG uptake, and the recommendation is for biopsy. The last category is definitive recurrence. These started as only path proven, but we added ones that have clear clinical and radiographic progression, and a recent study showed 100% positive predictive value in this category. Here's a very early paper on the initial performance of NI-RADS to predict recurrent head and neck cancer, and I think this is a great framework. You can see that we had 618 total sites we scored NI-RADS 1 in the majority, so 85%, and even out to 2 years, he's had a low rate of residual disease, 3.8%. NI-RADS category 2, we only scored this 9% of the time, so we only brought patients back for earlier follow-up in 9%, but that is warranted because you can see they have a higher rate of positive disease. 17% of those were positive. On the flip side, 83% were just post-treatment change. So the majority of these NI-RADS 2s are still just focal post-treatment change, but we want to draw attention to those and have either the surgeons take a look if it's mucosal or bring them back for earlier follow-up if it's deep. So NI-RADS category 3, these are the minority, only 5%, that we recommend biopsy. And you can see these have a much higher rate of positive disease. Here's an example of our template. The findings are succinct, saving time for the radiologist. You're basically looking at the primary site and the neck. And in the impression, you can score the primary, and if there's an abnormality, you'll use the pros to describe the abnormality that led you to that particular score. And you may or may not choose to put the legend with the linked management in the report. I think by even giving the score and your level of suspicion, you're moving the patient care forward. We do include the legend with linked management in our reports. NI-RADS 0 is a new baseline study, a new study to your institution where you don't have the prior imaging, but it is available. So you want to go ahead and assign the score and then create an addendum once that prior imaging becomes available. And this will serve as a safety net to prevent you from making mistakes and overcalling abnormalities without the prior. And that's what happened in this case of a base of tongue squamous cell carcinoma that presented to our hospital nearly a year after chemoradiation therapy with this level 2 lymph node that had too much enhancement. So this can't be a NI-RADS 1, but you don't want to jump up to a NI-RADS 3 and recommend biopsy without the priors. So the surgeons, if there are priors available, you're going to ask them, you're going to give it a 3. And then you're going to get those priors. And here now you see the 3-month post-treatment baseline. The node is completely stable and there was no FDG uptake at that time. So that makes us much more confident that this node is a NI-RADS 1. But unfortunately, that's not how this happened. We went ahead and called this a 3 without the priors. We did a biopsy, and when you biopsy a treated radiated node, they can often be really hard for the cytopathologist, and they called atypical squamous cells, and this person went to neck dissection, and so we have path proof that this was a negative node. NI-RADS 1 imaging features. This is at the primary site. You may see non-mass-like distortion of soft tissues, especially if it's post-surgical, or low-density mucosal edema, or diffuse linear mucosal enhancement. In the neck, if you do have residual nodal tissue, it's not enhancing, so it's hypo-enhancing, and there's no significant FDG uptake. And you can see this base of tongue primary with level 2 nodes on the 3-month post-treatment baseline, nothing at the primary site or the neck. So this is a 1 and a 1. NI-RADS 1 pearls and pitfalls. The major pitfalls are being familiar with the more complicated post-resection reconstruction appearance. In these patients, there's often false positives on the PET, and this is an example of tongue fasciculations, and this residual oral tongue tissue can look very mass-like. These are important to become familiar with to avoid that pitfall and overcalling that abnormality. NI-RADS 2 imaging features at the primary site. If the mucosal enhancement is focal or there's focal FDG uptake, we give it a 2A. These are likely going to be post-radiation change, but we point it out to our surgeons and oncologists so they can take a look. This helps them with their clinical exam and increases sensitivity as their exam is also difficult in the post-radiated patient. For the deep abnormalities, we give this a 2B if they're ill-defined and only have mild to moderate FDG uptake. It just means we need more data in the form of short follow-up or a PET to make a decision on what to do next. In the neck, If there is residual nodal tissue that may have a little bit more enhancement than you'd like or mild to moderate FDG uptake, we'll give it a NI-RADS 2 so that we can bring it back for short interval follow-up. Or later in the time course of surveillance, if there's an enlarging or new lymph node that develops, but it doesn't have definitive morphologic abnormal features like necrosis or extranodal extension, we'll give that a NI-RADS 2 because it's not high suspicion. Head and neck cancer patients can also have enlarging reactive nodes. And anytime there's a discordance between the PET and the contrast-enhanced CT, we will give it a NI-RADS 2. And this is an example of a base of tongue that was treated with CRT, and you can see on that first post-treatment 3-month scan, the contrast-enhanced CT has a small, non-enhancing, hypodense ulceration. But on the PET, there's intense focal FDG uptake, which may make some of us knee-jerk to call this a NI-RADS 3, but remember, when it's mucosal, we're going to give it a 2A, direct the surgeon's attention there. And this, at 3 months, the FDG uptake went away. Here's an example of an N3 node in the neck. This is larger than 6 centimeters. Often on the immediate 3-month post-treatment baseline, you will see some residual enhancement in this tissue and some residual FDG uptake. So this cannot get a NI-RADS 1. This would be a NI-RADS 2 at least, recommending short interval follow-up. So but by the time we saw this outside scan, we recommended an immediate new PET-CT, which unfortunately showed clear progression and now rises to the category NI-RADS 3, where we are going to recommend biopsy before salvage neck dissection, and this was residual disease. The pearls and pitfalls in NI-RADS 2 category, it often helps to work backwards. Do I want to biopsy this now? Is it a discrete biopsy target? If you're not the one doing biopsies, be in open communication with your interventional radiologist or whoever is doing the biopsy so that you can get feedback on the lesions that you're sending them. If it's ill-defined and there's not a discrete biopsy target, it's often best to wait, get more data, re-image, or get a PET. NI-RADS 3, for the primary site here, you're going to have a discrete nodule or mass that has concordant intense FDG uptake if the PET is available. In the neck, the residual nodal tissue here is going to have residual enhancement and intense focal FDG uptake. Or later in the time course, if the newer enlarging lymph node already has definitive abnormal morphologic features like necrosis or irregular borders. Here's a patient that had a huge T4B adenocarcinoma of the palate that underwent a partial maxillectomy. And on the post-op scan, you can see a focal area of intense enhancement on the PET that actually brought our attention to the abnormality on the contrast-enhanced CT. But when you look there, you saw an irregular margin of the bone and soft tissue. So it's meeting our criteria for a NI-RADS 3, even though it is sub-centimeter. So note that size is not part of the NI-RADS 3 classification. And when you look at the clinical notes, there was a close margin and the patient had refused XRT. So using all the information we have, this is very high suspicion. Remember, when you give a NI-RADS 3 that is not mucosal, this is clearly deep to the mucosa, they're going to likely ask you for percutaneous biopsy, so you can go ahead and be looking for different paths to get a tissue diagnosis, and we did prove recurrence in this case. This next patient had a nasal rhabdomyosarcoma, and this necrotic retropharyngeal node developed later in the time course of surveillance and was definitively had abnormal features of necrosis, and we biopsied this to prove recurrence. So can I use NI-RADS for cancers other than squamous cell carcinoma? Yes, I've just shown several examples. If you are just starting to use NI-RADS, you may want to start small with this subgroup of squamous cell carcinomas so that you can gain some experience first, and then broaden your template for other head and neck cancers. Pearls and pitfalls of NI-RADS 3. The biggest one that I've learned is that radiation injury to the soft tissue or bone can be very tumefactive and mimic tumor. And here I'm showing you the immediate post-treatment baseline PET-CT after a big T4A tonsillar cancer, underwent CRT, and there's an ulceration with enhancement deep to it and focal intense FDG uptake. But because it's mucosal, we really should give this a 2A. This turned out to be post-radiation, and you can see at 6 months that FDG uptake went away. Here's a NI-RADS 4, clearly a fungating mass at the stomal site for recurrence. This is definitive tumor. If you're thinking about using this at your institution, there are a lot of resources on the ACR page. You can see this category descriptor table, but also flowcharts that walk you through an abnormality. For example, at the primary site, deciding is it superficial, is it deep? If it's deep, is it ill-defined or is it discrete? If it is discrete, what is the FDG uptake? And then helps you decide on a NI-RADS category and next step. So for the last part of this talk, I'm just going to go over cases and lessons learned. And I want to emphasize how committing to a level of suspicion will help you individually get better, even though there may be ones that you're wrong. And I've shown some examples just of those mucosal abnormalities that early on I was calling high suspicion and learned to downgrade those to a 2A. But ultimately, I think it's the way that we all reach success and adding more value for our patients. So this next patient's a 57-year-old who underwent resection and reconstruction of big T4A. These are the ones that will often have some FDG uptake, but this is intense and it's very focal. And when you look on the CT, I'm not sure how well it projects here, but there is this irregular enhancement. And we gave this a NI-RADS 3. We were really worried about this, but when we biopsied it, we only got atypical cells. We didn't get definitive squamous cell carcinoma. So now you have a RAD path disagreement. So what if there's not RAD path correlation? Well, the answer is do not stop, and we've learned the hard way on this. If you can't explain it, or you don't feel comfortable that the imaging findings could be tumor-factive treatment change, you either need a repeat biopsy or a surgical biopsy. So it's important to keep up with these RAD path correlations. Here's an example just again of a tongue base that was radiated, a little bit of enhancement of the glossotonsillar sulcus and FDG uptake on that 3-month scan, gets a 2A. But the patient came back at 4 months of the earlier scan because of that 2A and had increasing enhancement and FDG uptake. Now, this is no longer just mucosal and they take a look. It's increasing over time. And this is one of the special scenarios that I will give a NI-RADS 3 for a mucosal abnormality. This patient also, clinically, they could see it. Clinically, there was pain. There were a lot of other clues. But this leads us to the frequently asked question, what if a mucosal lesion is highly suspicious? Can I give it a 3 rather than a 2A? Yes. But often on the first post-treatment PET CT, even focal mucosal abnormalities are often radiation related, especially if the FDG abnormality is a lot greater than the enhancement. But there are 2 special scenarios where mucosal lesions can rise to high suspicion. The first, if it's an increasing mucosal abnormality that's after that first post-treatment baseline scan, which I just showed you. And the second is if it's a new abnormality that is also beyond the post-treatment baseline scan. So here is a patient nearly 15 months after treatment for a laryngeal tumor and has an ulcerative mass, has new hoarseness, intense focal uptake along this right true vocal cord. So this is clearly a NI-RADS 3 and was a recurrent tumor. What happens if you image patients too early after treatment? So this patient, after CRT for an oropharyngeal primary, got their CT at only 4 weeks. So yes, these nodes look very irregularly enhancing. If this was at 12 weeks, we would be giving this a NI-RADS 3. Here you can see some residual uptake in these nodes. But generally, if they're not in the right time frame, I will give it a NI-RADS 2 and ask them to bring the patient back in the right time frame. But what happened in this case is also not unusual. The surgeon and the patient were too nervous about these, so they went for a neck dissection instead. And it was a completely negative neck dissection. And I think it's just a good learning case that they can look very irregular still with FDG uptake, but if it's not the right time frame, maybe false positive. So what do you do if the timing is wrong? You really need to wait to avoid false positives. So I'll usually score those in NI-RADS too. This next patient was treated for nasopharyngeal carcinoma with chemoradiation in 2014. So I'm reading the scan in 2019, and you can see the soft tissue in the carotid space is clearly increasing. So to me, that is high suspicion for recurrence. If you wanted, you could add diffusion, look at the ADC values, probably too small for perfusion, but it's really the change over time and the morphology of this that makes it highly suspicious. So this is one that is a rare NI-RADS 3 that I actually didn't feel comfortable biopsying. Usually when it's deep and I give it a 3, it's something I feel like I can biopsy. But occasionally the surgeons are going to have to do an endoscopic or open biopsy, and that's what they had to do here. We did the PET to add confidence before they went to surgery, but they did find recurrent tumor. Can I use NI-RADS on MRI? And again, yes, we're using a NI-RADS template on MR. We presented that at this past ASHNR and are currently working on a lexicon. This next patient had a maxillary sinus squamous cell carcinoma, had undergone maxillectomy and orbital exoneration at an outside hospital way back in 2016. And I'm being asked to evaluate this MRI in 2019, where you can see there was abnormal soft tissue effacement of the inferior orbital fissure, tracking back to the foramen rotundum. It also tracked down to pterygopalatine fossa. It would be easy to overcall residual tumor, recurrent tumor, and perineural tumor on this case. And while diffusion and ADC or perfusion can be helpful, really what you want to see is the prior. What matters most is change over time when interpreting a surveillance MRI. So you're going to give this a primary 0 and ask for the priors. And now you can see in 2017 that soft tissue was completely stable. And remember that after surgery at the primary site and after radiation, these areas and soft tissue abnormalities may remain abnormal forever. So important to beware of overcalling perineural disease progression at a single point in time. This next case is a 60-year-old male that had a right-sided T2 oral tongue and had an ipsilateral neck dissection that was negative. And on the very first post-treatment baseline, we see this heterogeneous left level 2/3 lymph node. The reader here gives it a NI-RADS 2, brings attention to it. I think this was a perfectly reasonable score and good discussion. Even though they thought the lymph node may be heterogeneous, it was still sub-centimeter, and the ipsilateral neck had been negative, so they wanted to get another time point, and they suggested a follow-up at 3 months. So when the patient came back at that earlier follow-up, now we can see which direction this node is moving. It's clearly becoming necrotic and gets a NI-RADS 3. We proved recurrence with biopsy, and this went to salvage neck dissection. So this is an example of how patients can move between different NI-RADS scores if the abnormality becomes more or less suspicious over time. The score can move from that NI-RADS 2 to a 1 or 3 or vice versa. This recent publication just shows the predictive value of our first post-treatment imaging and the value of NI-RADS. So you can see at the primary site, for every 1 unit increase in the NI-RADS score, there was a 2.6 times likelihood of residual disease. And for the lymph nodes, a 5.2 time increase for every 1 increase in NI-RADS score. Also want to highlight some recent publications by colleagues at UPMC and at Mayo, looking at the negative predictive value of category 2 and then the positive predictive value of categories 3 and 4. So this next patient had been treated for an adenoid cystic of the soft palate in 2011, and she was just undergoing MRI surveillance. And I think this really highlights how we can be correct, we can pick up the abnormality, we can describe it well, But if we don't give a level of suspicion, we don't move the patient's care forward. So in each one of these reports I'm going to show you, we described the abnormality, we compared it to the prior, we were technically correct, but it wasn't until we called it high suspicion for cancer that they went to the OR to remove this and proved that this was recurrent adenoid cystic. So you can see that we brought attention to this retropharyngeal nodes. We used words like somewhat concerning. We compared it to the priors, but it wasn't until we said, you know what, it's not really changed from the immediate prior, but it's still highly suspicious for recurrent disease. And we talked about even what are the next steps for biopsy. And 1 month after that report, they went to surgery. So to me, I learned the power of committing psychologically for us as radiologists, but also for our surgeons to give them confidence to move the patient care forward. This next patient, I'm including our clinical indications section of our template to show how we give the background. We also include HPV status, surgery date, and chemoradiation. So this information carries forward through each case that we assess. And in this case, the patient had been treated over 2 years for an oropharyngeal primary with CRT, and then develops this right 2B lymph node that's heterogeneously enhancing. It was too round. It had clearly enlarged compared to the prior. And you can see that this was read as a 3, high suspicion. And then we used the pros to describe the abnormality, a right level 2B lymph node. You can see that this reader wasn't as sure to go straight to a biopsy, and so they recommended a PET CT as being able to give us more confidence before the subsequent biopsy, but they still called it a high suspicion. And here you can see it's intense FDG uptake, and we biopsy to prove recurrence, asymptomatic recurrence, nearly 2 years beyond treatment. So in summary, NI-RADS adds value in that it simplifies our communication. It makes these reports easily understandable with numerical levels of suspicion. I would argue that it makes them easier to interpret. I think most of our trainees would agree these are ones that they actually, these are ones that they cherry pick off the list as being pretty straightforward to read now. So you can see this is an impression from an outside report, and we often do a great job describing the abnormality, and this was in the left glossotonsillar sulcus. But then our impression is that it could be neoplasm, mucositis, or infection. So, and we give no level of suspicion, which leaves the surgeons wondering, what's my next step? Instead, if you give this a 2A, it's a mucosal abnormality, say it's low suspicion, likely post-radiation, the patient's not as worried. The surgeon can just take a look and everyone is happy. So it clearly directs management. It's okay to be unsure of the diagnosis, but we need to be sure of the next step and commit to our level of suspicion so that we can learn and we can move patient care forward. I've shown several examples of why RAD path correlation is so important, also some examples of evidence-based practice, and finally, this really opens avenues for direct patient reporting and highlights the radiologist's added value. Thank you. I hope you all learned a little bit more about the post-treatment neck, and I can't wait until we can all celebrate and see each other in person again.